if that's okay, just conscious of time. I will continue to admit people throughout the session as well. So first of all, thank you so much for attending and taking time out of your evenings. I am recording the event, so we'll try and get that recording on the website. We'll share it with those contractors and pharmacists that aren't able to join us today. However, we do hope that as many as you can join, because we want to make the session as interactive as possible as well. So my name's Rajshri Owen. I'm the Chief Officer of Community Pharmacy Leicester, Leicester and Rutland, and it's a pleasure to be here tonight. I've got a couple of colleagues, including one of our guest speakers, who's Monique. She will be speaking shortly. She's from Exchange Supplies, and she'll be sharing some expert knowledge and also some practical insights to support our community pharmacy teams in LLR when it comes to delivering the NSP services. I'd also like to introduce Lach, who some of you may already know from Turning Point as well, who I know supports with some of the operational issues, but also just in terms of when we need some support in whatever issue when it comes down to client support around Turning Point services as well. So if you have any specific questions or any issues, feel free to pop them in the chat. Today, our session overview is really to focus and looking at NSP in terms of needle and syringe programme. And it's essentially the role that community pharmacies play in harm reduction. So we're going to be looking at harm reduction, the importance of pharmacy when it comes to NSP, the needle and syringe programme. And also on a more practical side, I think Monique's going to be looking at what's in the NSP packs and why things are in the pack as well, but also drug preparation and any associated risks with that as well. We do want to make the session interactive, so if you have any specific questions around NSP and the role of community pharmacy when it comes to harm reduction, feel free to pop them in the chat and we'll get through your questions or comments throughout this evening. I'm going to hand over now to Monique Tomlinson from Exchange Supplies. Monique, are you there?
I am here. Thank you very much.
Brilliant, pleasure.
So I'm just going to share my screen. Hopefully the technology works.
Yeah, we can see that. That's perfect.
Excellent. Thank you very much. Yes, so good evening, everyone. My name is Monique Tomlinson. I'm from Exchange Supplies. We're your supplier of all the injecting equipment that goes out from both the Turning Point service sites, but also all the pharmacies that are part of the NSP scheme across Leicester City, Leicestershire and Rutland. So, as mentioned, a bit of a whistle-stop tour tonight. I'm mindful we've only got an hour, so just to kind of a bit of context about harm reduction and needle and syringe programmes, the importance role that community pharmacy play, really important role. Going to look at some of the injecting equipment that you provide and why it's in your packs and why you actually provide it, and also how people actually use the equipment to prepare their drugs for injection and some of the associated risks. So who are we? Well, we're a social enterprise. We're based in Dorchester, actually, and been around about 24 years. We were established to supply products, and the first product that we actually supplied was citric in single-use sachets. We were the first to do that, and then it that became kind of on what we call the exempt list, Misuse of Drugs Act, that could then start to be provided from NSPs, and we've added to the range over the years. So we supply products, information. Our website is actually a web shop that not only do we sell to services, but actually a lot of individuals buy direct from us as well, people that just don't want to go into services for whatever reason. And really what we're about is keeping people as well as possible who inject drugs. So being a social enterprise means that we're principally driven by health and social objectives. We have to make money, but we're not just about the profit. Our key priorities: we want to reduce the health impacts of injecting drug use, of which obviously there's many. Over the years, we've been developing injecting equipment that causes less harm and we are increasingly doing so. But kind of we don't produce anything that's not as good as, if not better than currently on the market, because we wouldn't be able to sell it, and we wouldn't be able to sell it to services for a competitive price. So we're probably now the world's leading specialist of injecting equipment for people who inject drugs, which is great. We sell within the UK, but we also ship out globally as well. Importantly for us, we also provide employment and training to people with a history of drug dependence. About 30% of our staff team are actually people with living and lived experience. And for us, that's really important because we're providing opportunities for people that find it difficult to get a job and indeed retain employment. But also we've got an in-house focus group of people who actually use our equipment and know what's important for the community that we serve. So it's really important. So, you know, they're great at spotting, you know, what needs to be in a pack and any sort of issues. And that's what keeps us up to date. We're very much kind of working on the ground. And also a lot of us are from drug services. I used to work in a drug service across 3 boroughs in London. So we are different from other suppliers in that sense. And of course, it's what we really want to keep doing is improve the understanding of injecting drug use. Over the years, you know, new drugs come along, particularly important challenging time at the moment, actually, with synthetic opioids, high rates of drug-related deaths, also emerging image and performance enhancing drug use, which we're going to talk about later. You know, if people inject drugs, they are at risk of bloodborne viruses and various other complications. And actually also just to highlight, we actually do provide an NSP from our own premises in Dorchester. So this is just a photo outside. We've got a needle drop bin. So people come into our service in one of our units, which is actually one of our warehouses, and they can drop off their returns either on the way in or the way out, 24/7 access. And as you can imagine, we've got really good rates of returns, although we think that other people who aren't able to make returns to pharmacies, they're not necessarily our client group, but people who want to make returns of injecting equipment also, we think, use that because we have got incredibly high rates of returns. But that's fine because it's safe disposal. So needle and syringe programs. Now note, it's not really called needle exchange anymore, although obviously we all do still call it needle exchange sometimes. The global term is needle and syringe programs because the emphasis isn't on the return anymore. There isn't the link between giving out equipment and expecting people to make returns, because people return their equipment in different places. It could be to the drug service, it could be to a different pharmacy. So the main aim of needle and syringe programs is to reduce the transmission of bloodborne viruses, obviously HIV, Hep B and C, but also obviously to protect people against bacterial infections. So we're benefiting the individual, but we're also benefiting wider society. So NICE, they've produced 2 different sets of guidance, best practice guidance on the provision of NSPs. First one written in 2009, the latest one, 2014. And this is the one that's still deemed fit for purpose. And so we've got a wealth of global kind of experience and research that clearly demonstrates that NSP is an essential public health intervention and an incredibly cost-effective intervention as well. So when NICE produced the latest guidance, the remit wasn't to consider whether or not programs should be provided. It was actually to look at what is the best way to provide an NSP. And we actually did an audit tool as well for the implementation of the guidance, which you can download free of charge. All our publications are free of charge off our website, exchangedSupplies.org. So if you're interested in having a look at that, please feel free to go there. And so in the guidance, NICE obviously makes a number of recommendations. And one of them obviously was that each area should use a range of outlets, including pharmacies, specialist NSP, such as Turning Point, service and other healthcare settings. You know, you have NSP being provided from a range of different settings, sort of hostels, homeless centres, etc. And so you provide a balanced mix of the following levels of service, so a wider range of people can access. So we've got level 1, level 2, and level 3 is really the kind of the specialist drug service, such as Turning Point. So most pharmacies really fall within level 1, usually providing packs, which you obviously do across your area, and maybe some written information on harm reduction as well. So level 2 is a more kind of specialist pick and mix bespoke with kind of more specialist information. But also just to flag up that we have an e-learning portal, training.exchangepsuppliers.org, which actually is endorsed by NICE and in keeping with the best guidance. And there's level 1, level 2. So I would strongly encourage you, if you haven't already looked at that, it's free, it's open access, to go there. Level 1 takes about 30 minutes. You get a certificate at the end of it, but I think that's really useful to kind of inform and develop best practice as well from your pharmacies. So NSP, the hierarchy of goals. Well, what we really want to do is reduce sharing of injecting equipment. We know that people, if they have new sterile equipment, they will use it. If they don't have access, if there's limited access, then it's not going to stop them injecting. They will just share, either share with other people or reuse even their own, which can present bacterial infection issues. What we also want to do is reduce the frequency of injecting by getting people into treatment, but also providing interventions such as the provision of foil so that people can smoke their drugs as opposed to inject their drugs. As I mentioned before, the primary aim of NSP is the provision of new sterile injecting equipment. Some people say we should be flooding the market. We still don't give out enough new injecting equipment in the UK, even though we do have a very decent NSP provision in comparison to a lot of countries around the world. We still don't give out enough equipment to enable everybody to have a new set of works every time they inject. And it's thought that most syringes are probably reused about 3 times plus. So primary aim, get the new equipment out there. Secondary aim, collection of returned equipment. We always want to encourage people to make safe return. However, sometimes that isn't possible for a variety of reasons. So please always give people their equipment, even if they don't make the return. So a question that's often asked is how much to actually give out. So obviously NICE made recommendations around this. We should provide people with the right type of equipment and advice for their needs, and the quantity provided should not be subject to a limit. So if somebody comes in, a really good question to ask is, are you picking up for yourself or are you picking up for others? Because sometimes, well, often people will come in and they'll pick up for themselves and maybe a partner. They might even be picking up for 2, 3, 4, 5 people at the time. So they might actually want more than 1 pack. Sometimes people come in and they'll ask for 10 packs. If you've got enough stock, that's the caveat. If you've got enough stock, then there's no reason why you can't actually offer that amount of equipment. If it's looking like you're short of stock, or if you order from us, from your web shop account before 2:30, we aim to ship out that day, and you should get it within 1 to 2 days. So you don't need to keep a lot of stock on site, but you can quickly order if you get sort of unexpected demand. And we never want to discourage people from taking equipment for others, because secondary peer needle exchange is a really important, legitimate way that people get their equipment who don't currently come into services. And as you probably know, people don't come into services, pharmacy or drug treatment services for a variety of reasons, often to do with fear, stigma, women with children, often they don't particularly like coming into services. So it's really important that we give people not just what they want, but actually what they need. So another important question is to ask, you sure you got enough? As I mentioned before, NSPs are really cost effective, and obviously NICE set out a cost statement, the benefit of supplying NSP, in their guidance. And so the latest guidance, they illustrated that, well, they estimated, and given it was about 10 years ago, I guess we need to increase that by X amount, but estimated that it cost £202 per year for somebody who injects imaging performance, somebody who injects psychoactive drugs, and somebody injecting imaging performance enhancing drugs, for example, steroids, about £6 a year plus dispensing costs. So it's not an expensive intervention when you compare it to the cost of treating somebody who with Hep C or HIV. It could cost £250,000 over a lifetime of treating somebody with HIV. Luckily, the treatments for Hep C have really come down over the last few years, but it's still expensive when you compare it to the cost of the equipment that you actually provide. So why is pharmacy such an important outlet? Well, because you're the backbone of UK NSP, and you have been since the late 80s, when we first started to scale up NSPs. For example, there's 4 Turning Point services across Leicester City and Leicestershire and Rutland, but there's 44 pharmacies alongside that. So really what you do is provide local access, obviously convenient opening hours for people, and discreet services. You're also important in terms of engagement of people who inject drugs, observing people over time, and also assessment. And clearly an important outlet for new sterile equipment, a means of safe disposal, and also providing any support and advice to people as they might need. I mean, often, as you probably know, people come in and they'll kind of quickly just want to come in and quickly get out. But some people want a kind of a longer engagement to be able to seek kind of additional support and advice. So just to kind of flag up current trends, challenges that we face, or that our clients face, and just to kind of pick up on a few of these. Obviously, drug markets are more dangerous than ever, with increasing numbers of potent synthetic drugs across the UK. For example, in 2024, there was 195 deaths linked to nitazene, which is a very potent synthetic opioid. And in fact, that 195 was 4 times higher, the link to death, than it was the year before, 2023. So we're getting kind of nitazene. It's similar to fentanyl in terms of it's about 50 to 100 times more potent than heroin. And obviously with the shortage of heroin because of the clampdown by the Taliban in Afghanistan, we're getting these heightened risks. Hence, we're getting kind of higher than ever drug-related overdose and drug-related fatalities. And in fact, of the drug poisoning deaths registered in 2024, 3,736 were identified as drug misuse. So that's higher than ever. And we've also got now, interestingly enough, this emerging issue of people using peptides, also coming into services and pharmacies. You might be seeing this happening within your pharmacy. I was certainly speaking to some pharmacies the other week, and they were saying they're definitely starting to get people coming in for new injecting equipment, and indeed to make returns. And so people using peptides such as GLP-1, weight loss, others for apparent healthier hair, skin, muscle growth, which is kind of being fueled by social media and influencers talking about these sort of things. And also, I guess one of the good things that is really happening, really happened over the last few years, is greater access to naloxone. So obviously some of the pharmacies on the scheme, you're now giving out Phenoxad, and you can see how important that is in terms of drug-related deaths and preventing overdose. And in fact, the government's going to be legislating again soon to increase the coverage even more of naloxone. It's such an important kind of thing to do. And complications associated with injecting, well, clearly there's many, not just bloodborne virus risk, but deep vein thrombosis. People groin injecting potentially could lead to amputation, as well as poor nutrition, mental, physical and dental health. Many clients are vulnerable to a range of bacterial infections because of poor hygiene and non-sterile equipment if they have to share or reuse, and indeed just the environment in which people inject. For example, injecting on the street, public injecting. And so, I mean, there's been surveys carried out among people who inject to ask what they want from community pharmacies, what they actually value. And really, I guess they value what we all value, which is discreet, confidential, user-friendly service. They also want a choice of injecting equipment in quantities to meet need, also advice and information. Sometimes they want to see and speak to pharmacists and staff. Certainly they want sometimes more than just an exchange, and feedback from somebody said to someone just to ask if you're okay. And so basically, what else can you offer? Well, compassion, respect, develop the relationship. Really good to, and I'm sure you do already, but really good to try and build up a rapport. The more people can trust you, the more they will come in and the more they will open up and hopefully start to speak to you if they have any additional needs. Make every contact count. Advice about BBV transmission, overdose prevention, particularly if people are coming out of inpatient hospital stays or prison, really important that they have access to naloxone, obviously, and indeed foil as well, because tolerances become low. And also, obviously, your role is to signpost people into drug treatment and Hep C testing and treatment services. So really good to know where your local turning point service is in relation to your pharmacy, and even just basic stuff like advising people to always use new needles. We know from feedback that sometimes people don't get an effective injection. They need at least 4 hits before they will get an effective injection. So basic stuff like always use new needles, rest veins, clean hands, don't share is really important for our client group. So all of the equipment we provide has 2 purposes. Clearly to reduce the risk of bloodborne viruses, vein damage, associated health problems, and as an engagement tool, because if we give people what they want, they will come in. And they appreciate quality equipment. So that's what we always aim to do, a range to meet people's needs and quality equipment. However, everything we provide also carries a risk if used incorrectly. So it's good to have an understanding of the risks associated with using the equipment. For example, people tend to overuse acidifiers. The acidifiers that you supply, like citric and Vit C, they come in single-use sachets, and people think, oh, there's not much powder in there, so they just bung the whole amount in. But actually, as you'll see in a minute, you actually only need about 1/3 or less of each of the sachets, and hardly anything at all to get the drugs to dissolve in water to enable injection. And it's really important the issue of making sure people have enough needles, because we don't want people to be injecting with blunt needles. Because this is a photograph of a needle that's never been used, and this is what it looks like when it's been injected through the skin, searching for a vein. And as you can see, not only do you get metal fatigue, it's not uncommon for people to come into services, or maybe you've seen people with needles that have literally broken off in their arm or indeed groin. And obviously you would always send somebody to A&E in that case. But as you can see, when a needle feels blunt, this is what it looks like a nasty sort of fish hook or sort of a crochet needle. And I've actually seen people inject, and when they're injecting, they're saying, oh, this needle feels really blunt. And that's through the needle having been used several times. Because sometimes people, they might live quite away from a service or a pharmacy, and they might not be able to kind of visit frequently enough to pick up enough equipment. So what's in your packs? I know some of the pharmacies also do pick and mix provision. So the main syringe that's basically used, given out, is a 1 ml Unisharp fixed needle syringe. So that's the 1 ml Unisharp fixed needle syringe. It's called a fixed needle because it's fixed during manufacture. So we, in 2007, we produced the world's first licensed syringe, it's called a 1 ml never share, specifically for injecting drug users. So we get our equipment from big global manufacturers, and then we work with them to bespoke them for our client group to maximize control and ease for self-injecting, because obviously if you can control your injection, you're less likely to cause harm. So we did the 1 ml never share in 2007, and this is kind of second generation really, and this is the 1 ml fix that you provide in your packs and also from your pick and mix. So Unisharp, it's got 30 on the barrel of this, which means 30 gauge, but you have 29 gauge in your packs, and you provide the 30 and the 29 gauge from your pick and mix. So couple of things just to note. It's a really high quality needle. It needs to be really sharp. People really appreciate sharp needles. Colours are important for our client group, and I'm going to show you a film as to why colour-coded equipment is really important to reduce bloodborne viruses. So we have 5 different colours plus white across our 1 ml fixed needle syringes, and indeed across the 2 ml syringes that you have in your NSPs. You'll notice on this 1 ml we've got larger finger grips so that people can control the injection better. You also give out 2 ml, 2.5 never share syringes and 1 ml syringe barrels. Now different needles. As you can see, we provide a broad range of needles. Obviously, a broader range is available in the Turning Point services. So if somebody comes in, you provide orange needles, blue needles, green needles. If somebody comes in and they want grey, brown, black, then good to refer them to the service where they'll be able to pick up a broader range of needles. Pre-injection swabs, citric and Vit C supplied, spoons and filter, water for injection, 2 ml glass amps, and a safe amp snapper, which hopefully you order for the pharmacies that do pick and mix. Obviously sharp spins. Now you've got sharp spins within the packs, but just to say, if you've not looked into the pack content, the sharp spins come with a loose lid. And your syringes are packed inside the sharp spin, and then when the syringes are ready to take out, you pop the lid on and you push it down and it locks into place. And the reason why we don't have lids on our sharp spins, or indeed labels, is to no label means it doesn't scream out injecting drug use, so people are happier to carry the bins around with them, but also having the ability to pack equipment inside the bins means less bulk for when you store it, but also less bulk when people need to carry them around. And obviously, importantly, also now I know a lot of the pharmacy, a lot of you are also providing naloxone, the injectable panoxide kits as well. So coloured syringes. Why were coloured syringes developed? So why have you got coloured syringes in your provision? It's because a big piece of research done in 2004, where in Scotland, researchers led by Professor Avril Taylor did some surveying of people coming into services. They got some really good information about how people injecting behaviours, where people inject, etc. But they thought, right, we're going to do some kind of fly on the wall. We want to see people actually injecting in a whole range of different environments. So they just sent out a couple of researchers to record people doing what they do, basically. So that with the aim of identifying where bloodborne transmission virus transmission was occurring. So I'm just going to show you a 3-minute extract as to what they found and why we then went on to develop colour-coded syringes.
The aim of the study was to examine in detail the injecting practices of drug injectors, with a specific focus on the factors which may lead to transmission of hepatitis C. We also identified, though, instances of indirect sharing, And these could took place in two ways. First of all, by mixing up needles, and that could occur where you had injectors who either lived with another injector or who injected habitually with another injector. Now, in one instance, for example, we had two females who were living together and didn't actually want other people to know they were injectors, so they actually stored or hid their needles and syringes in a nest of coffee tables. And we actually saw them retrieving those needles and syringes on one occasion. And when the needles came out, it was quite easy to see that there was no way of knowing which needle and syringe belonged to which female in that house. So you? Now, one of the reasons that mix-ups occur so frequently is because the vast majority of people in our study used the fixed 1 ml diabetic needle and syringe for their injections, and therefore were unable to tell one from the other. I think 88 out of the 103 injections we saw were with a fixed 1 ml needle and syringe. And out of those 88, only 11 were marked in some way to distinguish them for further use. Some people burned with a lighter the end of the plunger so that it was blackened and they would know it was theirs the next time. Other people scraped one of the numbers off the barrel again so that they could distinguish that needle and syringe was theirs. This was also able to let them know the number of times they had used that needle. So if there was 3 numbers had been scored off it, they knew they had used that needle 3 times previously. One of the things that we found in this study was this potential to mix up needles and syringes. And the reason for that was that the vast majority of injectors were using the same kind of needle and syringe, in this particular instance, the 1 ml fixed needle and syringe. I think what we have to find is some way that the injectors can actually distinguish between these needles. And that might be by producing the syringes with a different colour on the top rather than just the orange. It could be that we could produce the needles and syringes in a different kind of format. Maybe the barrel could be rough or a different shape or whatever, so that people who are living together could each pick a different type of needle and syringe to be used just for themselves.
So off the back of that, we thought, crikey, we really need to do something to enable people to be able to identify their own equipment in the event of reuse, because you saw living examples there of people being confused as to whose syringe was who, because they all looked the same. So that's when 3 years later we managed to work with B. Braun. Not many manufacturers wanted to work to produce syringes that were specifically for injecting drug users, but luckily for us we managed to persuade B. Braun, and we produced the 1 ml Never Share, which is actually the B. Braun Omnicam insulin syringe, and we managed to persuade B. Braun they should add colours into the plungers, and now coloured syringes are now accepted as best practice, not just within the UK actually, but also overseas. The UN Development Programme buy coloured syringes from us, and the World Health Organization also talk about identification schemes so that people can enable the use of their own equipment and not mix up accidentally. So yes, that's the sort of the range. And now, as I said earlier, the 1 ml Unisharp is the next generation of colour-coded syringes that we now supply. So just to be clear, in your packs for the pharmacies that just have pre-filled packs, you have, if it's a 10 syringe pack, you have something like, for example, 10 blues, 10 pinks. It's not a mix of colours within each pack, because the assumption is one pack is for one person and another pack is for another person. So if somebody comes in and they pick up 2 packs, odds are they are going to pick up different coloured syringes within each pack, if that makes sense, so that people will be able to identify their own syringe if they're injecting together, which of course we want people to do, so that in the event of overdose, somebody's on hand to call the ambulance and administer naloxone. So the other thing that's the new thing, the other new thing, although I won't say it's new because it's the thinking has really been around sort of 15 to 20 years now, but the other thing that's really accepted globally as best practice is the use of what we call low dead space syringes, low dead space injecting equipment. So there's a researcher called Bill Zoll, who we subsequently worked with, and his theory was, do low dead space syringes prevent injecting related HIV epidemics among people who inject drugs? So he looked at HIV sort of at, when he was thinking about it sort of 20 years ago. Subsequently, there's been other research done about low dead space injecting equipment around hepatitis C. So again, I just want to show you a quick 3-minute video. Our founder, Andrew Preston, talking about what dead space is and why it's important for our client group.
So this film will explain the meaning of the term dead space in injecting equipment and clarify the terminology that we use to describe the 4 different types of needle and syringe combination that are available from needle and syringe exchange programs. So dead space is the void space that exists in a needle and syringe from the end of the plunger when it's fully depressed to the tip of the needle. The reason that dead space is significant is because when people are injecting drugs, they know that there's wasted drug in the syringe, in the dead space. And what they do to get the drug out is they do something called flushing. They pull the plunger back, partially fill the syringe with blood to mix it with the drugs, and then they inject that. And it means that after injection with illicit drugs, the dead space is filled with blood. And obviously that is a bloodborne virus transmission risk if the syringe is then used by someone else. So we used to think that all syringes were equally dangerous and that if they were shared, there was an equal high risk of bloodborne virus transmission. But we then realized that when you have a high dead space syringe, because there's more blood, there's more virus in that blood, and it survives for longer. So high dead space syringes represent a much greater risk of bloodborne virus transmission than low dead space syringes. When needle exchanges first started, there was just basically 2 types of needle and syringe combination available. There was a fixed 1 ml syringe with the needle attached during manufacture, which has a very low dead space of only 3 microliters. And then there was Lewis slip and Lewis lock syringes for detachable needles, which, because there's a void space both in the tip of the syringe and in the hub of the needle, that has a dead space of about 100 microliters. Unfortunately, it's not possible to just stop giving out high dead space syringes for detachable needles because people need detachable needles either because the length or the thickness of needle that they require isn't available in a fixed needle syringe, or because they need to change the needle during the injecting process because it gets blunt when they're looking for veins. So steps were taken to try and reduce the dead space in syringes for detachable needles. And there's 2 solutions to that problem, which have varying degrees of success. So the first solution was what's called a low dead space needle. Now, low dead space needles have a plastic spike in the hub, which goes down into the tip of the syringe, filling the void space and reducing the dead space significantly. So a low dead space needle attached to a syringe has a dead space somewhere between 10 and 35 microliters. The other partial solution to the problem is a reduced dead space syringe. Now, these syringes don't reduce the dead space as much as you might think they do, because although the spike on the end of the plunger fills the tip of the syringe, it isn't able to go into the hub of the high dead space needle that fits onto it. So the dead space in a reduced dead space syringe needle combination is about 50 microliters. In order to reduce harm, we want to reduce the dead space as much as possible. So in order of risk, there's fixed 1 ml syringes, which are low dead space syringes, which have around 3 microliters of dead space. Next is low dead space needles, which have the plastic spike, which goes down into the tip of the syringe, which reduce the dead space to between 10 and 35 microliters. Then there's reduced dead space syringes, which only reduce the dead space by about 50% to 50 microliters, because the dead space is all in the hub of the needle. And then finally, the highest risk with 100 microliters of dead space is a high dead space needle and syringe combination.
So it turns out these 2 syringes are not risk equivalent. A 1 ml fixed needle syringe has got way less blood than a sort of a detachable needle with a detachable barrel, which wasn't really thought about prior to Bill Zoll's research. But now it's regarded as absolute best practice. And the good news is Turning Point Fund the best equipment possible. to go out from the pharmacies and their own NSPs. So you have the range of what we call the total dose needles, which are low dead space needles, which, as Andrew said, reduces the dead space, not just in the top of the syringe, but also, as you can see, the little spike in the hub of the needle. And so you've got orange, total dose, blue and green, blue and green in your steroid packs. And also in the 2 ml packs, you've got an orange and a blue needle. The other thing that we've obviously, there's the lowest dead space is always going to be a 1 ml fix, but for various reasons, not everybody can use that. So what we've done over the last few years is we've also increased our range of 1 ml fix. So now we've got a 1 ml fix that's actually got a 1-inch orange needle on the end of it, and also a couple of 1 ml fixed that have got blue needles on the end of them. So people don't need to use detachable barrel with a detachable needle. So we're trying to reduce the amount of dead space in syringes as much as possible to cater for more people who wouldn't normally use that. So Turning Point Services have got the new 1 ml fixed with the oranges and the blues, but hopefully coming to pharmacy pick and mix as well. So I'm just conscious of time. Normally at this point, I would get out the equipment if it was an in-person training session and actually show you how to prepare drugs for injection. But I thought it's way more useful to actually show you one of my colleagues actually preparing drugs for injection, so you can see it better on camera. So here we go.
In this film, we're going to show you how heroin is prepared for injection. We do this because for most people in health and social care, heroin injection is a million miles from their day-to-day experience. And we find that by showing you how it's done, we both humanise the process and help make sense of the equipment that you're giving out. Here, my colleague Jane has 100 milligrams of heroin, a dose that costs £10, and she's going to tip it into the spoon, ready to prepare for injection. Almost all the heroin sold in Britain is brown heroin, manufactured mostly in Afghanistan for smoking, and it doesn't dissolve readily in water. So the first thing that Jane has to do is add a small amount of vitamin C powder. You can see she's only used a very small amount of the vitamin C powder in the sachet. And in fact, before she started, we weighed the sachet with the powder in it, and it weighed 710 milligrams. And afterwards, we re-weighed the part-use sachet, it was 680 milligrams. So a £10 bag of heroin only needs about 30 milligrams of vitamin C powder to get it to dissolve, which is about 1/10 of the sachet. With the water added, the next thing to do is to add some heat. This is just to help accelerate the reaction of the heroin dissolving in the water with the assistance of the vitamin C powder. The technique is to move the flame around the bottom of the spoon, bringing all of the liquid to a gentle rolling boil and then removing the heat source. You can see here that the heroin has gone completely clear, and that means that it's all dissolved. Now, sometimes if there's other plant matter or adulterants in the drug powder, then it won't dissolve completely. And often then people keep adding acid in the hope of breaking it down and making the solution go clear. Unfortunately, the extra acid usually just results in additional vein damage and isn't dissolving any extra drug. Finally, a filter is added. This is because the solution still contains particles of plant matter, and if these are drawn into the syringe, they can turn round and as the solution is expelled, can block the needle. So it's really important that there's no particles drawn up into the syringe, and the filter helps remove all of these. This process of drawing the drug through the filter into the syringe takes a little bit of practice. It's important not to pull back too quickly, because if you do, you just fill the syringe with air. And that's how you prepare heroin for injection. In this film.
So hopefully a lot of information to take in, but hopefully that's given you a much better idea of why you provide the equipment that you do and how that equipment is actually used, and also why it's really important, why your role is really important in terms of kind of providing essential new sterile injecting equipment to our client group. There's my number and my email. Please always feel free to contact me directly. I'm your account manager, always happy to take any questions at any point in time.
Brilliant, Monique. Thank you so much. That's been really informative. I know I've certainly learned a bit in terms of what you've presented today as well, but also re-emphasised some of the things that we think we know as well around the service provision and offering that service. I'm just going to go to the chat, and I know Lac has been busy trying to answer some of the comments. There haven't been many. We did get a couple, which was around the, perhaps you might know a little bit around this, but well, actually, just going back to all the comments, Altaf is one of your, is a contractor himself, but also provides a service. And when you talked about peptides, he did say that's obviously really emerging and really common. Peptides for muscle recovery in particular as well. So I don't know if there's any other comments from anybody that's joined the call, but that was certainly evident in his comment. Paul's asked around occupational health issues that pharmacy teams or team members, contractors should consider in relation to their employees, like a Hep B vaccination. Is that something that you've been asked before, Monique, around that?
Yeah, well, I mean, obviously, drug workers and other healthcare professionals working with people who inject, it's always recommended, although it's not mandatory, to have a Hep B vaccination. Because, of course, the environment in which you're working in. I mean, you should be able to get it free from your GP. Should be able to get it free. But yes, it's always a good thing to do if you're happy to be vaccinated, for sure.
Okay, so Paul, do you want to come in? You've got your hand up around that.
Yeah, I don't think wouldn't it be counted as an occupational health service, and in the current contractual environment with primary care, that GPs would say that they're not contracted to provide occupational health services. So I would say that to be very cautious if pharmacy owners and managers are sending patients to their staff to ask their GPs. I think that they might not get that answer that they want from their GP. I don't know the answer, unfortunately, to that where small pharmacy contractors would potentially direct their patients to other contracts on here may have already considered that, but I don't know but it was just something that crossed my mind. But I don't think general practice in truth is a solution to that.
I mean, some people, certainly I've known some colleagues to have Hep B vaccination via their GP, but you're right, it's yes. It totally depends.
It shouldn't be like that. It's a mess.
No, I know.
Let's be right, but that is the reality. That is the reality.
Yeah. I don't have a definitive answer to that either, I'm afraid.
Sure,
generally,
no problem.
that's recommended.
Yeah, it's absolutely recommended, but as I say, not mandatory. So,
okay. Lac, is that something that the that Turning Point are looking at as well? Because if it's a general issue around pharmacies are providing the service.
I think we've been asked about this once before, so I've had a word with Mo. We're going to raise it and see what they come back with, and then I can let you know what answer we get.
Amazing, that'd be great. Thank you.
No worries.
That's good. Thank you. And there was a couple more, mainly from Paul, wasn't it? And I know, Lac, you're picking that up around up-to-date list of pharmacies. So thank you for providing that, and we'll get that across to Paul. The only one I don't think was answered was around geographical gaps. Are there any geographical gaps in LLR? Whilst we've got an audience with some of our LLR contractors, do you know of any specific gaps where there's no service provision?
I do have a map which I can look through. I know just off the top of my head, we have no one in Hinckley providing the service. ODB areas like that, it's usually the county areas where we tend to have a lack of services. We're quite good in the city at the moment, but there are still gaps in the city as well. I can again come up with a bit of a spreadsheet or something, giving us an idea of what areas are covered, what areas are not. And if anyone is interested in providing services in areas that are not covered, then we can look into getting that set up.
And that would be great. And if there are contractors, because we've had a few new pharmacy owners as well, in terms of if they're interested in providing the service, what should they do? Who do they contact? Is it yourself or is it
Yeah, just
Mo?
contact me or contact Mo. Either of us would be happy to help.
Okay, if you can pop your contact details in the chat as
Yeah,
well for everyone to pick
definitely.
up, that would be great. So Paul, do you want to come in on that?
Not on that, a completely separate question that I've not put in the chat.
Okay, yeah. Yeah, go for it, Paul.
It's just about the colours.
Mm.
There was a slide around colours. The syringes, the needles come in separate colours, and then you've also got colours for the plungers. Is that?
Yeah, so the colours are the plunger and the cap.
Yeah.
It's not the needle. The needles are, the needles are the needles. So it's just the cap and the plungers. And then obviously in a 2 mil, so it's the 2 mils and the 1 mil fixed actually. I know on the pick and mix there's 1 mil barrels, and I think they're just all right. But obviously, again, on the 2 mils, it's just going to be the plunger because they obviously don't have caps because there's no needle. So on the 1 mil
the
fixed,
needles don't come in different. The
no,
separate needles aren't color coded, because I thought I saw a slide and there's about 9 different, but no.
the needle is the needle. It's exactly the same needle, no matter what color. It's just the plunger and the cap. And then on the 2.5 mils, the 2 mil barrels, it's just going to be the plunger. Does that make sense?
Yeah.
Brilliant, thank you. And just one question from myself, and if anybody's got any questions, feel free to pop your hand up as well, or pop it in the chat. In terms of sometimes I'm often asked around referral pathways, and that's normally in hindsight to a conversation or an incident that's happened. Are there any specific referral pathways that our contractors or pharmacy teams should be using or actively using, if they're in LLR, that you're aware of, either of you? I guess it depends on the nature of the need, but is there an exhaustive list? Because I find that we've kind of I've pulled together a list of organisations that potentially may be of help, but I just wonder if there's some kind of a bit more of a robust list in terms of supporting pharmacy teams that may be asked about additional services, or pathways that patients may or clients need to access.
When you say referral pathways, do you mean additional help for the clients?
Yes. Yes.
Okay. So, for example, if they were to come in and ask about injecting equipment, we would always ask that you refer them back to Turning Point. We have specific dedicated team members who can talk to them about the equipment that they need, things like that.
Yeah, it's not so much of that. It's more
Mhm.
about, I guess it's the cohort, the demographics, isn't it? They're often from very deprived backgrounds and probably need support around housing, social and economic help around
Okay.
benefit claim, things like that. So I wonder if there's some kind of list that we
Mhm.
could work on if it's not been done, that supports them through providing them with information, local information around charities, organizations that could, voluntary organizations as
Mhm.
well. Because often, I mean, I know, having spoken to a number of contractors, they'll get asked about how to fill out this benefit form. That's a really simple example, but they do get
Mhm.
asked that. And that's, so there might be other needs of other than just about the service provision, because they come to the pharmacy and actually that's probably one of their few healthcare professional contact points,
Mhm.
or contact points at all. So yeah.
There's definitely a list that we might have that I can look into providing for you.
That would be great. Yeah, that would be
So I'll
helpful.
get
We
back to
could
you with
post
that
that on
one
the
as well.
website. Thank you.
Yeah.
That'd be really helpful.
No
Brilliant.
problem.
Are there any other questions from anybody on the call today? We're all very quiet. No. Can't see anything. No. Okay, feel free to pop your hand up. Paul, you've got one. Sorry. Go on.
Well, that collect. So there is right. Sorry for my naivety. And obviously there'll be pharmacy owners on this doing this day in day out who know it all. But so apologies for that. Obviously I'm a little bit more remote. But right. So there is the option to bring back to pharmacy, isn't there? Used kits. So then what? Who picks them up?
So Turning Point manage the collection of waste, clinical waste from NSPs across your area. We manage it in one or two other areas, but not in your area.
It's a separate to the standard pharmacy waste contract.
Yeah.
Yes.
So we will arrange, once we have a new pharmacy set up, we arrange for a bin collection. I think it's done once a month unless it needs to be done sooner, and it's with an external company.
Okay. Thank you. Okay, any other questions or comments from anyone? Okay, well, thank you, Monique and Lach, for joining us this evening. It's been really informative. Generally appreciate your time as well. I'll encourage our contractors to get in touch with you, Monique, if they have any comments as well, or any questions going forward. But I want to say truly thank you for your time this evening, and thank you for a great presentation. Thank you so much. Thank you to everyone that's joined our session this evening. It has been recorded, and I will pop it on our website shortly as well, once it's been okayed and authorised by Turning Point as well. Lach and Monique, thank you so much, and have a great evening, or what's remaining of it. Thank you, everybody.
Thank you.
Thank you.
Bye-bye.
Take care.
Good evening. Bye-bye.
Bye-bye.